Welcome to another edition of Cancer Specialists Medical Minute.
With Dr. Rick and Dr. Danny.
That's Dr. Rick.
And that's Dr. Danny, and we're excited to be back.
Is it dad joke time?
I think it is.
Ooh, Brenna's excited. I think she's the most excited about these dad jokes.
I don't know. You came prepared this time, so I really think it's you.
Wait, last time he wasn't prepared?
Well, I didn't have to print out any jokes for him this time.
All right, fair enough.
I'm bringing it to the table. Here we go. Where do you take someone when they've been injured in a peekaboo accident?
I have no idea.
To the ICU.
So anyway, it's going to be a first here on Cancer Specialist Medical Minute. We have a guest for the first time. Some of the feedback we got, according to producer Brenna, was that Rick and Danny were really annoying by themselves and they needed someone to kind of add a little more flavor to the mix. Did you hear that as well, Danny?
I heard some whispers of that. I think we have a great guest today, and I'm very excited to get started here.
No, that's true. And we're going to be talking about immunotherapy. And we have with us one of our colleagues, Dr. Trika, who works down at our St. Augustine location. He's board certified in infectious disease and hematology oncology. And he is going to teach us, especially me, obviously, a lot more about immunotherapy. So welcome aboard, Dr. Trika.
Glad to be here. Thank you so much. It's good to be here where I get to feel more important than I really am.
I wouldn't say that. You're very important. But if you could just kind of give us a real brief kind of your background, how you got here and joined the practice.
Great. So let me actually back up a little bit. So I'm originally from India, and that's where I did my med school, and came to the country in 2005. Did my residency up north. This was a tertiary care center in northeast Pennsylvania, a place called Sayre, Pennsylvania, at the Robert Packer Hospital. That was a community center. And then I came down as a faculty at University of Florida at Gainesville in 2009. Did a year of being a hospitalist, and then I did my first fellowship, which was infectious diseases, for 2 years, and then I was a faculty for the 2 years after that. Now that's when I gained the passion for taking care of immune compromised hosts, and that's where I sort of like fell in love again with training, should I say, and went back and did my second fellowship, which was hematology oncology, and then here I am to my friendly little town, weekend getaway of St. Augustine. And which me and my wife thought would be a good place to raise our family.
Definitely.
Right. You're clearly a glutton for punishment with all that training.
And I got married, yes.
Now I'm interested to hear, did someone talk you into or, talk you into learning a little bit more about hematology oncology, or was it your experience in the hospital when you were on rounds and learning about the different patients, and what got you kind of interested in pursuing that fellowship?
Yeah, it's quite interesting you asked me that. So one of my mentors up in when I was still in infectious diseases, now he collaborated a lot with my second mentor. So the two were Dr. Ramphal and Dr. Wingard, and they sort of like they had a quite fine collaboration and taking care of like infectious issues in stem cell transplant patients. So one thing led to the other, got involved in research during my infectious disease training, and then I sort of like was the go-to when I was a faculty for infectious diseases for the stem cell transplant group. And yeah, then it sort of like it just kind of evolved in a meaningful way for me, where then I was like, okay, let's just take it up as a challenge and get into oncology, and rest is history.
From my experience in bone marrow transplant, it feels like we consult ID about every patient.
It felt like that. In fact, like in a good way, I would say that, it gave me a very different perspective. How, immune system actually really evolves after stem cell transplant is quite fascinating. And to the day, I'm still kind of, I go back to the basics, and a lot of my understanding of immune reconstitution after transplant is still down to my infectious disease training. And so I'm quite excited about this topic of immune therapy.
Mm-hmm. Well, allogeneic stem cell transplantation, that's a good lead into immunotherapy.
So, as the radiation oncologist sitting on this panel, You guys are throwing out a lot of big words that are confusing to me and maybe to others listening. You said allogeneic stem cell transplant. Can you kind of walk us through a little bit more details what that actually means?
Definitely. I can understand why that's confusing. The basics of an allogeneic stem cell transplantation are that a donor who volunteers to donate bone marrow can harvest their stem cells in two ways, either from the bone marrow or from their peripheral blood getting hooked up to a machine which actually extracts stem cells. And those stem cells are used for patients who need a bone marrow transplant. Those patients can be patients who are afflicted by leukemia, certain lymphomas, and it goes into a lot of detail of which diseases and which patients benefit from this type of transplant. But basically, there's a donor who's either related or unrelated to the patient who gives their stem cells and are infused into the patient afflicted by that blood cancer after a round of chemotherapy. And the benefit of the stem cell transplant is to eradicate any living leukemia cells or living lymphoma cells by using that donor's immune system and those immune cells to attack the cancer left over in the recipient. Probably one of my first kind of interest in hematology was on the transplant ward and learning about these patients, and it is kind of one of the first immunotherapies in terms of you're using someone's stem cells and using those immune cells that are donated to hopefully fight any residual leukemia, lymphoma in the body. Did you have a particular case or experience on the transplant ward that even made it more clear that this was your calling?
Almost like, yeah, that, it's quite funny. It's almost like very vivid. Transplant it's a boot camp. No two ways around it. Your immune system is completely, you're dropping a bomb on your immune system, and it's like literally rising from the ashes. And for us, it used to be like the third through the fourth week. That's when we used to literally be like, there used to be a phrase called pray for polys, which was, okay, you want your neutrophils, which are like our Navy SEALs, the first ones at the scene regarding infection, really saving us. So until that happened, you were really on the tender hooks about, okay, now what's the next infection? It's not if, it's when. And you could almost predict by the week which infections you will actually might end up with. And case I remember, I was rounding on a 20-odd patient day when one of the stem cell attendings, just said, somebody's having fever, go and check him out and tell me what's the infection. Yeah, looking up the nose was a practice back then, and I'm glad I did, because we found a mucormycosis suggestive necrotic plaque in the nose, which, just knowing when the risk of infection of a certain kind, which is a fungal invasive infection, tends to happen more so starting from the second week in a neutropenic state, can really make you seek, because your eyes only see what your mind knows. And that case didn't end up well, but case in point being that how much your immune system really dictates your risk and recovery. A case like that, had the neutrophils recovered in time, probably would not have seen the unfortunate infectious complication.
Can you walk through, Dr. Tricca mentioned neutropenia, what does that mean, and when a patient's neutropenic?
So all neutropenia means is that you have a low neutrophil count. Neutrophils are white blood cells, and this is common after receiving chemotherapy. There are certain chemotherapies which cause more neutropenia or eradicate those neutrophils, which are white blood cells. And the significance of neutropenia is that it puts patients at risk of certain infections. As Dr. Tricca said, these are the first soldiers to go and travel in the body to the site of infection. And when you have less of them, infection risk is higher, and the severity of infection can be much higher too. So we have to recognize severe neutropenia. We have to sometimes put patients on antibiotics preventatively. And of course, if a patient is displaying signs of infection, we have to treat it.
That's pretty wild. I mean, I think, the patients and people listening hear a lot on the news, and there's TV advertisements for immunotherapy, and it clearly is becoming more and more on the forefront. But I think you guys are right. I mean, stem cell and really is a bomb to the immune system, and seeing the sequelae after that. But can you give us kind of just a history and explanation for those of us who are less initiated with immunotherapy, kind of how we got to sort of this modern era of it?
Right. So, the immune therapy that we talk about, or what we mention, is very different than, that about from something like an allogeneic stem cell transplant. The immune therapy we are talking about is mostly the most popular and widely used are PD-1 and PD-L1 inhibitors, which, just from a very basic perspective, the cancer happens, I would say for two reasons. One would be that, our immune system is blinded by the cancer cells. It's almost like a break the cancer has on the immune system, or something is feeding the cancer. Not that we eat sugar doesn't feed the cancer cells, as best as I understand, but certain proteins, be it like from mutations like EGFR, ALK, fusion, RET, so on and so forth. So those are the two reasons. And immune therapy, where it comes into our benefit, is that the break the cancer has on the immune system is what the immune system is able to lift, which then invokes the immune system into fighting the cancer. Now, easier said than done, because we know for a fact that lot more people don't benefit with immune therapy than actually the ones who benefit. And but the catch here is that once it happens, then for some of our cancers, the results can be just fantastic. And we've seen it, we've all benefited. And it's funny that all three of us, I would say younger folks, who've seen this evolution in the last, I would say last decade, where melanoma, kidney cancer, lung cancer, head and neck, to name a few, we've just seen some amazing results.
One of the first things I remember when I started oncology fellowship was one of my first patients I treated was a patient with metastatic non-small cell lung cancer. And at the time, we did not have immunotherapy that we can give up front for treatment. So the big decision was, which chemotherapy were we going to give to this patient? Of course, we did have some targeted therapies, EGFR inhibitors, ALK inhibitors, but those mutations are quite rare. This patient did not have one of those mutations. So, you basically choose a combination of two chemotherapy drugs, and the data is not good. I mean, the median survival in some of these trials was about 9 months, and maybe 12 at best. So you're talking about half of patients are going to live, less than a year with the best therapy available. And I think, as Dr. Tricca said, the changes that have been made over the past 5 years and the treatments we've been giving, either immunotherapy by itself or immunotherapy combined with chemotherapy, have yielded far superior results, and particularly those patients that respond to immunotherapy, because again, the ones who don't, unfortunately, still don't have a very good prognosis, but the ones who do, we're seeing cases of stage 4 lung cancer which appear to be cured, and that's almost unheard of, in the era 10 years ago.
It's interesting, maybe it's just a function of hype and everything like that, but it's important, I think, to understand, for patients to understand sort of what is a realistic expectation. And yes, I think when you have someone who responds well, you're obviously seeing things we've never seen before. But as medical oncologists, how do you guys, when you see a patient in the clinic who's a candidate for immunotherapy, kind of walk us through sort of the counseling process, sort of saying what is the expectation of response and side effects and those sort of things?
Yeah, so I would say that I started a very sobering note of back in the 90s, early 90s, when we had very limited understanding of lung cancer per se. Everybody used to get chemotherapy, not knowing what cancer we're treating. So less than 6 months back in the 90s, a stage 4 lung cancer. Fast forward to the mid-2000s, when we actually understood the histology of the non-small cell adeno versus not adeno. And yeah, I think the number doubled somewhere around the ballpark of 10 to maybe 13 months. And that actually held up for a fairly long time, from the mid-90s to 2005-06. Now, since then, fast forward to that next era, I tell my patients that, a lot depends upon the histology and then the biomarkers, where you separate out, very clearly these days, like, some people who have what we call actionable mutation as in a target that we have a medicine for, which is about 25% of the entire group. More so with, non-smokers and Asian populations we've seen, females especially. And the rest 75%, which, unfortunately don't have a mutation as yet, but we have now the immune therapy. Now, the I would say the biggest benefit of immune therapy has been that that 9 to 12 months, if you actually add immune therapy to our standard of care chemotherapy, that goes up to I would say a median overall survival of anywhere between 18 to 24 months. And that's a range because if you look at most trials, with different combination of drugs plus the immune therapy, which whatever, like there's 4, 5, 6 options now, gives you that range. Depends upon patient selection, if you ask me. And to the most amazing accomplishment, I would say, is that there's a small group where, depending upon a PD-L1 biomarker, what we call a high, expressor group, there per the Keynote 024 trial, I think the 5-year update just came out. There we are seeing a median overall survival like literally 24 months. All right, and that with only chemotherapy, immune therapy, non-chemotherapy option altogether, which is just quite fascinating. And adding to it, there was a combination of immune therapy trial which hasn't taken attraction much. This was the nivolumab and the ipilimumab, not endorsing the product, but there's some group which benefits amazingly, as in like people who respond to the combination at 6 months, and we don't know who that group is. They actually are living up to, like, the 3-year survival is 70%. Okay, that tells us that the immune therapy works for a few people, but when it works, the durability is just amazing. The next challenge, I would say, in the immune therapy era is going to be finding that biomarker or biomarkers that can really help predict, okay, these are the folks you really need to give immune therapy only versus the chemo immune therapy for the rest.
I think that's been the challenge is the right biomarker, because at best we're talking a high PD-L1 expression, 50% or higher. Response rates are still probably roughly 45 to 50%,
right.
Maybe higher for the 100% expressors, slightly higher.
Yeah.
But so, you're only still capturing about half of patients. And if you look at another marker that, is reported in some of the next generation sequencing that we do on tumors called tumor mutation burden, that's been studied more on the combined immunotherapy arm, and high tumor mutation burden also yields about similar kind of results as far as roughly maybe half of patients with the high TMB will respond to combined immunotherapy, but they're great responses and a lot of the time durable. So I think that's where the optimism comes, is that, you have a patient that responds, they're likely going to respond for a while. And a while meaning years, a while meaning possibly cure.
Can you talk to me a little bit about biomarkers when you mention that, PD-L1, that sort of thing? What are we looking at, or what's being done to check for those different things?
So biomarkers generally are proteins that we're identifying on or in the cancer cells, which can be targets for certain therapies for different types of cancer. So we basically do this analysis on all tumor tissues which are submitted. We request a comprehensive analysis which gives us data on which proteins may have certain mutations which make it more likely for that patient to respond to a certain treatment. PD-L1 is a biomarker used for immunotherapy. PD-L1 is a programmed death ligand 1, and higher expression levels of this protein, PD-L1, correspond with better responses to PD-1 and PD-L1 inhibitors. There are other biomarkers which are used in different types of cancer. Dr. Tricca spoke to us about a couple of them being EGFR and ALK mutations. These are activating mutations which we think are driver mutations for why the cancer is growing in the first place. And we do have certain therapies which are beneficial to patients and can be administered in pill form.
So basically, if the cancer is pressing down on the gas pedal, and your medicines may stop that.
Correct. Yeah, these activating mutations, which have oral therapies or even IV therapies, which can target them, will put the brakes on that growth by targeting that mutation, which is feeding the fire.
And I got gas and gas pedals on the mind. My wife and I have been watching the F1 series on Netflix. I don't know if anyone else watches it. It's pretty awesome.
I've heard of
Formula One.
Yeah.
Never really got into it before, but now I'm a huge Formula One fan after watching it. So highly recommend for the listeners out there.
Are we going to do a trip to Monaco sometime soon, Dr. Rick?
Sign me up. Are we allowed to go? Yeah.
Of course.
I think
of
we're
course.
allowed to go.
As
Yeah.
long as it doesn't interfere with the podcast recording, that's fine.
So mean.
I've got a great
Demanding.
idea. Great idea.
We
Do an
record
episode or
there.
two in Monaco on CSNF.
Love it.
Let's do
Twist
it.
my arm.
Perfect. If you were to give advice to a patient or a caregiver who comes into the clinic, what key questions should they be asking, about immunotherapy, or what should they be asking about their tumor to their oncologist to make sure that they're getting all the information they need?
Yeah, I think, the question to ask is understanding what type of lung cancer or what type of cancer you have. And I think a good question is, what is the chance of response to this treatment? I think the chance of long-term survival is really with immunotherapy based on response. And if you can tell the patient that you have a 20% chance of response or even a 50% chance of response, it gives them a better idea what to plan for. Because 20% chance, they may need to think about planning for, possibly the worst, but you always try to remain optimistic because it's hard to guess who's going to fall into that 20%. But I think, asking what are the chances of this working, and, reviewing side effects with them too, because there are certain caveats with the immunotherapy, even though they're much better tolerated than chemotherapy. For certain populations of people, they need to understand what some of those side effects could be.
I think that's totally agree with that. I would say that one of the things we tell, or I like to be clear with the patients is like, what's the intent? Okay, are we trying to cure or are we trying to palliate? Meaning, that can make a huge difference altogether, because now immune therapy, we are using it in earlier stages, which actually I feel we are curing. We're curing, I think, lung cancer. We're curing melanoma. We're curing kidney cancer. We'll see, but there's a lot of hope there. And then second thing is that immune therapy is like, it's not immune suppressive. It's not like chemotherapy. This is something that for the most part, if everything goes well, you might be on it for years together, for the effectiveness and for your body to be able to put up with it in terms of tolerance. Now, in terms of can't agree with you more in terms of giving numbers, because that's such a big strength to a lot of our patients. But that one patient sitting across from me, for me, the big thing is that, like, I cannot tell you which side of the curve you're going to fall in. The best idea of whether we're going to succeed or not is going to be a first scan in 3 months, 2-3 months, whatever. Now, that is going to tell us whether you're going to be a responder or not. Depending on that, now, honestly, if you have a response, chances are you're going to keep responding. Okay. Versus if not, then yeah, we are then between a rock and a hard place. Okay, that's one. Number two, I would say that where immune therapy differs from chemotherapy is that for the most part, for 10 patients on chemo versus 10 versus immune therapy, chances are immune therapy patient is going to do well in terms of, if not effectiveness, at least in terms of the side effect profile. Okay, but those 2 or 3 patients, the unpredictability of immune therapy, the side effect wise, is what the patient needs to understand. And the issue is that the side effect can happen anytime. With chemotherapy, it's very predictable. If it happens, it happens. It's almost like a blueprint. With every cycle, how you feel, for the most part, you feel the same way, right? Immune therapy can be slightly different. You have this whole spectrum of side effects. Some people have none. Some people have skin rash, some diarrhea, some lung-related symptoms. Rarely you have some, thyroid issues. But for the most part, Yeah, it's quite manageable, and you have the control with steroids. You can suppress the immune system, but immune therapy is not chemotherapy.
No, and I just anecdotally, as a radiation oncologist, I mean, to echo everything you're saying, it's very interesting to see in that vast majority of patients who are on immunotherapy are tolerating it. Most of them don't even know, wouldn't even know they're on a medicine if they didn't come in and get the infusion. And then you get the occasional patient that has a lot of issues, but it's obviously few and far between, which of course makes a huge difference in quality of life and how they feel. So no, it's amazing and very interesting to hear about.
Let me make a side note here, because we are in the COVID era, and patients may be asking, can I
What gave you
get
that idea?
COVID-19 vaccine during immunotherapy? And the answer is yes. I try to advise patients to do it between their doses of immunotherapy, not the day before, not the day after their immunotherapy. Dr. Tricka, do you have another recommendation for a patient?
Now you know as much as anyone else knows, which is like our understanding is fairly limited.
Mm-hmm.
But I would say, like, I don't know if it's out of context, but there's a recent paper from in context of CLL patients and myeloma patients where they saw that unfortunately the response rates to COVID-19 vaccine wasn't great in terms of the antibody levels being checked 2 weeks from the second shot. But wait for it. Nuance was that for the 2.5 months the patients were followed, not one patient got infected. So point being that even if we think might not be effective, please go and get your shot.
I don't think there's a downside. I mean, and that's really the point is, even if you're not generating the same antibody levels, there clearly doesn't appear to be
Downside to it.
any downside to it.
Well, let's move on to just another, interesting, I think, part of immunotherapy. I think one of the experiences I had in fellowship was IL-2 therapy, and this was one of the therapies that preceded your immunotherapy that we give in clinic now, the PD-1 and PD-L1 inhibitors. So IL-2 therapy is given in the hospital. It's interleukin-2. It causes a robust immune response in the body, which largely was given to patients with malignant melanoma and renal cell carcinoma. The data for IL-2 was not as good in a unselected patient population as your new PD-L1 and PD-L1 inhibitors. Dr. Trigger, do you have some experience with IL-2? Do you refer patients for IL-2 in the current era where we have these immunotherapies that we can just give in our clinic versus sending a patient to the hospital?
Yeah, it's one of those therapies that I just heard about and read about and know enough to not to think about. No, it was one of those wonder drugs that worked so well that it actually could be fairly tough and toxic.
Yeah.
If my memory serves me correctly, I think the overall long-term benefits were seen, but I think it used to benefit maybe less than 20% of people, if that. But yes, back in the day, preceding the PD-1, our I would say like the PD-1, PD-L1 era, that was the only curative option that we used to. But having said that, every attending of mine or the teachers that I've worked with used to gloat about it, how many people we referred back then, a whopping 0. Okay. But having said that, I think we've gained so much from IL-2 therapies because that was our sort of like the preface. Our understanding was based upon what immune therapy can do. And, I'd like to also mention just before, right at the cusp of ipilimumab coming through for melanoma, which was one of our first success stories. Okay.
Right.
Just preceding that era, I had treated a patient of mine with cutaneous melanoma. It was a stage 3. Back in the day, we used to have interferon therapy. Now that used to go on for a year. And this very kind gentleman, I used to work at the VA hospital back then, vet, he was like, okay, I don't know, can you help me make a decision? And I'm like, well, I'm not supposed to, but I'll tell you what, if it's my father, I would give it to him. Not knowing what the side effect intensity can be, but obviously seeing the benefit, a first year fellow. So I had the right intent. I think maybe a month or two later, we had to stop the treatment because of, it's like, how the side effects are much akin like you get up with a flu every single day of your life, right? This guy is like, I think months, I don't know exactly when, but like a few months down the road, he's like, okay, I stop. Okay. Then he comes back and sees me in the clinic and he's like, I just have one question. I was like, what? He's like, do you like your father? So yeah, that's sort of like, to me, is like, where the era we have come from, thanks to the current immune therapy we have, are so effective. And the tolerability, I cannot impress more, is so much better. And we feel like in so much more in control, where the question is not about like starting or stopping and it is really benefiting versus like, okay, I'm going to cure and I have the control.
No, I think that's right. I mean, in going back to the original point of what's the intent of therapy, and in the cases cure versus palliation, if the medicine you're giving them is causing them a worsening quality of life, what are we really accomplishing? So I think that's one of the most impressive things about modern immunotherapy is even if you're not in that super responder category, in general, people are tolerating it so well that it's worth a shot. You're not hurting them in the day-to-day life, which I think is important to keep in context.
Yeah, and my dad was on interferon when I was little, when he had melanoma the first time, and it was crazy. I don't remember a lot of it, but from what I do, it was insane. And when he was re-diagnosed, I kind of talked about it on the last podcast, but when he was re-diagnosed when I was in college, the IPI and the Nevo had just gotten like FDA approved like 2 weeks before, and they started him on it, and you wouldn't even know he was sick. And he had a tumor in his shoulder that shrunk and hasn't grown since, spots on his lung that haven't done anything and are pretty dormant, and it's literally like he's not even sick. It's incredible. So I mean, just the comparison firsthand is insane.
It's wonderful that you mentioned that, because the line between palliation versus cure, if anything has challenged more than anything, is immune therapy. Because like the chances of cure, we see that with every cancer. Not every cancer, I'm getting ahead of myself, but like some of the common cancers, like we could have not melanoma. I remember that having a discussion and somebody telling me like chemotherapy, like melanoma used to laugh over chemotherapy, 8-month survival, stage 4. And now it's like if you don't make that mark, somebody can question you why, if it's not an option.
I think, to me, one of the important things, at least when I see patients, is you have to define terms.
Right.
And Dr. Turkey brought that up earlier, is really, what does cure mean? What does palliation mean?
Right.
What does treatment mean? What is treatable?
Right.
Is something treatable, but is it curable? And
Right.
these are words that folks in the non-oncology space, things get tossed around, patients get confused. You go on the internet, you read different things. Obviously, Dr. Google is always a dangerous game to play. So I think that, my message to patients and to caregivers who are listening to this is really ask your doctor, really press them for those details, because it makes a difference, and those words matter, and understanding the differences between those words matter. And I think it really helps everyone involved frame expectations and what are we really trying to accomplish in a given situation.
Right. Yeah. I think even with palliation, like that it can be used in such a good way. Like for me, it means like you maintaining goal, like quality of life. You're helping symptoms, and yes, you are going to try to kind of within that parameter, you're going to make them try and live long as much as possible. And when literally like cure is, I tell them in a stage 4 setting, is a function of two things: a negative scan and time.
Mm-hmm.
The longer you have a negative scan and the longer it carries on that way, who knows?
Yeah, that's one of the most asked questions, I think, people who are on immunotherapy for a stage 4 malignancy is, can I come off of this at some point? And
Right.
It's a big question mark. I don't think we have clear data. I mean, there is data coming out for different cancer subtypes, melanoma, non-small cell lung cancer coming out with some data, but the optimal time, is it 2 years, is it 5 years down the road? That has yet to be determined, I think.
Correct.
So.
Correct. Yeah, I think because it's amazing because we talk so much about immune therapy and these targeted drugs, but the fact is we've just had them for an X number of years. And unless you really have those long-term, updates on these trials, it's difficult to kind of take somebody off of treatment who's doing well and not having side effects. Yeah. So.
And what's also interesting, as far as defining patient expectations and kind of looking at immunotherapy in cancers which don't respond very well to it. One of the cancers that come to mind where we use immunotherapy is small cell lung cancer.
Correct.
It does not have very high response rates to immunotherapy, but we all probably have a patient or two on immunotherapy who actually have a good response to it. I think it's very challenging, especially, in I'm going to flip to a different subtype, but in bladder cancer where they've started to take away the approval for certain immunotherapies because of new phase 3 data that's come out that doesn't improve on survival compared to the standard treatments. And all I'll say is it is difficult because we all have patients that do benefit in these different subtypes that may not respond as well. And I think it definitely makes us need to have more research as what the optimal biomarker is and why are certain patients responding and why others aren't. And we're not there yet for those types, but I hope we do get there someday.
No, I think your point is well taken. As excited we are, but yet we have to be cautious.
Yeah.
Not every cancer is melanoma. Not every cancer is kidney cancer. For every one of those, we have small cell where the benefit seems like month and a half in terms of overall survival. And you just might not be the perfect fit for it. So immune therapy, as exciting as it can be, in this day and age, we need to press our care provider. What is the scientific rationale behind it? And what are we really chasing? Are we chasing rainbows, or are we really having an objective scientific data?
I think that's perfect, and patient selection is going to be the key. And I think as we do more studies, do more research, as maybe different agents come out, we can really potentially hone in on finding that the holy grail. Someone gets a diagnosis, their tumor gets sent somewhere, they run every analysis under the book, something tells you, okay, you're going to respond to this. This is going to work 100%, but obviously we got a ways away before we get there. But I think there's a lot of progress happening on that front.
There are definitely labs looking into that.
Well, really appreciate your time, Dr. Tricca, putting up with Danny and I. I know we're not the easiest people to be around, so I really appreciate you coming into the Lion's Den and helping us out and explaining things, because certainly you did a much better job than I could have at explaining it.
We really appreciate you being here. As Rick said, I think your expertise and background in infectious disease has really, enlightened a lot of people, given them a lot of good information to think about and talk with their providers.
No, thank you so much. I think this is, fantastic to be able to reach such a, I would say like a large group of patients, hopefully benefits. And thank you for the opportunity, really.
It's our pleasure. No, absolutely.
All right. So wrapping up here, Dr. Rick, do you have any big plans this weekend? Any fun events coming up?
Not really, to be honest. Pretty boring weekend. Gonna try to make sure my toddler doesn't destroy our home, himself, our dog, my wife. Standard weekend fare.
Standard stuff. Well, I'm on call this weekend, so I will be on the road, hospital. The wife, the kids have some birthday parties to go to, so that's always fun.
So family gets to play while daddy is working. Is that the bottom line?
That's how it is, Rick. Yep, that's how it is. How about you, Brenna?
Going to see my niece and my new nephew.
Oh, congratulations.
Thanks.
Very
Congrats.
nice.
Pretty
yes.
cute. Did his newborn pictures a couple weekends ago, so gonna go
Yeah.
spend some time snuggling him.
That's
and,
awesome.
Kind of love that.
Brenna's also has a side photography business.
I do.
We can plug it on the
Thanks.
podcast.
Yeah.
We can, yeah.
I'm sure your parents are already aware as the OG listeners.
We actually have some more reviews
Shout
on
out,
Apple
shout out.
Podcasts. So we have 4 reviews now.
Okay.
One is from Ann and Keith, my
OGs.
parents.
Shout
Okay.
out.
Yep.
Shout out
Okay.
to the OGs.
Yep.
We love them. The other one is from my roommate.
Okay. Nice.
We like
All right.
it. We like it.
Was it a
Yeah.
positive review?
It was.
Okay.
They're all positive so far.
Okay, good.
Highlighting the dad jokes mostly? Or?
Yes.
Yeah. Okay.
I thought it was your intimate knowledge of three-peats.
Three-peats, yes. Yeah. Cleveland
Well,
sports.
And so we got another
Shout out.
one. We got another review, and I was like, oh, this is great. I don't know who this is. And then my other roommate texted me.
Oh,
Oh, okay.
So it was from her. But then we actually have one that I don't know who it is. So
all right.
Yeah.
so we're
To
doing
you, to you, anonymous listener, this episode goes out to you. We love you. Thank you for taking the time to subscribe, rate, and review. I think that's what the kids
Yeah.
say.
Yep.
Yeah.
Yep.
Someone's gonna email me as soon as this comes out and be like, "Oh, that was my review."
Yeah.
Probably Bob. It's
It'll
probably Bob.
it's
Yeah.
probably
Yeah.
my mom,
Yeah.
and
Yeah.
that yeah.
Could
'Cause
be
she
a
did-
family
my
member.
mom-
Where are your family's reviews?
My mom listened and she said, "I'm embarrassed to leave a review," and I said, "Thanks, mom. I appreciate
That's
that."
a nice
No, she
thing
didn't.
you
She
said.
didn't. I love you, mom. She didn't say that.
Did you
So-
get your family to listen?
So my dad's listened, and I'm gonna have to ask him about why I haven't seen a review from him. He's not.
Do you really want to ask him that?
He's not an
might
avid
not like the answer.
typer, but he might be mad that I said that. But but I'm gonna get
Is
him
he a
to,
hunt,
to
hunt
do
and
it.
peck?
Yes,
I
hunt
love
and
it.
peck. Yep.
Nice.
Yep. He didn't have formal training, so that was the problem.
Mad respect to the hunt and
Yeah.
peckers out there.
Yeah, but he got quicker over the years,
Nice.
for sure.
Yeah.
But we're gonna have to see some more reviews. Let us know your feedback. I mean, we're happy to answer any questions on future episodes. So please, if you have any questions out there that you'd like Dr. Rick or I to answer, could be medically related, could be unrelated to anything medical. We're happy to give you a shout out and answer any question you have. So if you have any suggestions on things we should talk about, questions you like answered, or just want to say hi, you can email us at medicalminute@csnf.us.
And make sure to follow us on social media. Search Cancer Specialists of North Florida on Facebook and _CSNF on Twitter and Instagram. And do I even need to put in the obligatory TikTok? Are we there? We're not there?
Ooh.
I made it.
You made
Ooh,
it?
No, I
TikTok
No,
account.
dang.
I just
I really got happy for a
I
second.
know.
Aw.
wish I recorded your reaction.
One of these days we'll get on
That's
TikTok.
awesome. As always, we appreciate you giving us a few minutes of your time and hope you learned something today. And remember, when it comes to your health, stay informed.
Ask questions
And
and tune in next time.